Welcome to Allergy Morning Commute, optimizing the treatment of hereditary angioedema. Morning Commute is developed by Projects in Knowledge and powered by Kaplan and is part of a continuing medical education series. This independent CME CE activity is supported by an educational grant from BioChrist. In this final podcast in our series, Dr. Mark Rydell and Dr. Alina Banerjee discuss the currently approved treatments for hereditary angioedema, the importance of an early and accurate diagnosis, as well as individualizing treatment options. Information about the faculty and disclosures can be found at morningcommutepodcast.com/HAE2. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Rydell is a professor of medicine and the clinical director of the Angioedema Center at the University of California, San Diego. Dr. Banerjee is an associate professor of medicine in the Division of Rheumatology, Allergy, and Immunology, and clinical director of Allergy and Clinical Immunology at Harvard Medical School in Boston. I am your host, Candace Hoffman. Dr. Rydell will begin our discussion.
Hello, everyone. Welcome to our second podcast in this series on hereditary angioedema. I'm Dr. Mark Rydell. I'm a professor of medicine and an allergist immunologist at the University of California, San Diego. And I'm again joined by Dr. Alina Banerjee. Dr. Banerjee is at Harvard Medical School and on the faculty at Massachusetts General Hospital. Welcome, Alina.
Thank you, Mark. I'm looking forward to our conversation this morning about treatment for patients with hereditary angioedema.
Excellent, excellent. Me as well. So in our last podcast, we discussed the clinical presentation and the diagnosis of hereditary angioedema. In our podcast today, as Alina just mentioned, we're going to focus on management of hereditary angioedema, or HAE for short. And we're going to talk about the currently approved HAE treatments, but also talk about the important principles of managing HAE as outlined in the evidence-based published guidelines for hereditary angioedema. Lastly, we'll talk a little bit at the end about some emerging treatments as there's ongoing clinical research to try to improve the management options for HAE. So, Alina, let's start with, I guess, kind of the big picture. We've made a diagnosis of hereditary angioedema. We're going to discuss treatment. What are the goals of treatment? What are we aiming for here with managing HAE?
Yeah. It's a great place to start. And I think certainly, as you mentioned, first, early and accurate diagnosis, right? That's the verbiage, that's the terminology. We all agree to that. So that's been done. And now we're thinking about what are the basic elements of a treatment plan. And I think it's certainly individualized, right? We keep using this word because it really is about the patient that's sitting in front of you. What are their goals? What works for them? What is their day-to-day like? And what do they want out of this? Is it somebody who's a teenager thinking about college? Is it a 25-year-old professional who's going to be traveling a lot for work? Is it a 12-year-old that's thinking about playing sports? And understanding those key concepts and thinking about quality of life and burden of disease in the broad scheme of creating an individualized treatment plan, and also knowing that it is not a one point in time, that there's regular follow-up. The plan can be modified, it can be changed, and making sure that all of those are discussed with the patient up front. And then certainly we can talk a little bit more about all patients should have on-demand treatment, thinking about long-term prophylaxis and where that fits in. But we can then talk about those elements specifically with the patient that's sitting in front of us.
Yeah, so a ton to unpack there. I mean, you hit on all of these important things. And so just so we sort of bring it back to what our patients with HAE are going through, as people hopefully know from the first episode of our podcast, this is a condition that leads to recurrent episodes of severe swelling. It could be skin swelling, it could be intestinal swelling, it could be airway swelling. And so as you just mentioned, Alina, these symptoms, this condition is very disruptive. It's very debilitating, and let us not forget it is life-threatening. So these are people who have a life-threatening illness. If the swelling, angioedema hits their airway, there is a very real risk of asphyxiation. And so I always like to start with, the goal of treatment. I guess the lowest bar is to keep people alive, is to keep them from dying from this condition. And so, as you said, we'll get into the strategies we use to make sure that that's the case, that people do not have to worry about dying from HAE. But it's much, much more than that. And again, we'll get into the details of everything you said. But as you mentioned, that they can work, that they can go to school, that they can play sports, that they can travel. It really is, as you said, reducing the morbidity, but also the interruption or disability associated with these recurrent, very severe episodes. And there's a big burden of disease, as you said, and we're really aiming to improve quality of life. And just a reminder that to the audience, there's a very recent consensus document from a group of global HAE experts that shows 100% of them agree we should be aiming to normalize people's lives with HAE. So as we talk through the treatment options, just keep that in mind, that really we would like for HAE to become sort of an afterthought. Not that we can cure it, we can't, but that we can keep it under control to the point where people really go about their lives with their therapeutic or management plan, and sort of do what it is they want to do in life without HAE becoming interrupting that, or being an obstacle in the way. So Alina, we have that's the big picture. That's great, and that's important to keep in mind. But in the clinic, we have to sort of get down into the details, right? So walk me through, you're setting up a management plan, you have a diagnosed patient. What are the first couple of things you talk about in terms of, the nitty gritty? What's the plan here in terms of treatment?
Yeah. So I think different physicians approach this differently, but my approach is to start with on-demand treatment. And the reason that I start with on-demand treatment is that I think that every patient should have on-demand treatment. It's similar to, if you know that someone has a peanut allergy, why would you not give them an EpiPen, right? So same way to think about it in my mind for hereditary angioedema. And so we first start with the on-demand treatment options, and we talk about subcutaneous versus intravenous. We talk about home self-administration and what tools will that individual need to make sure that they're able to self-administer at home. And if they can't do that, how can we make sure that they have the ability to have access to an on-demand treatment to be given as quickly as possible? In that context, for on-demand treatment, we will talk about having at least 2 doses of on-demand treatment at all times. We talk about treating as early as possible, because we know from the data that if you treat early and you prevent the onset of swelling, or you prevent the swelling from progressing, that is going to have the most benefit, because these on-demand treatments don't make the swelling go away. They actually prevent the swelling from getting worse. And so to treat the attack as early as possible. And then to stress that all attacks are eligible for treatment. And that tends to be a little bit more challenging when I'm talking to patients. And the reason for that is many of them have gone for many years without access to treatment, or the treatments are expensive. And so they will often reserve their on-demand treatment for that more severe attack. But that's a continual conversation that I have with our patients. And then we'll talk about the specific treatment options that they have within the world of on-demand. Then we go into long-term prophylaxis, and it's the same conversation. Do you want to be on long-term prophylaxis? What are the benefits? What are the cons? What are the different treatment options? Subcutaneous, intravenous, oral, et cetera, and kind of walk our way through all of those. And then it's really that patient giving me feedback and making a decision together.
Great. And so just to circle back, you outlined perfectly, what the evidence-based guidelines tell us. So the evidence-based recommendations are, first and foremost, make sure every patient has an acute or on-demand treatment. And as you just said, this is medicine to be used when a swelling attack starts. So used as needed, on demand. And we have actually 4 FDA-approved therapies that have been proven to, as you said, stop these attacks when they start. These, just so we're clear, these are very specific to HAE, right? These are medicines that are targeted at the so-called contact system, the kallikrein bradykinin system, which is the mechanism by which swelling attacks occur in HAE. And so we have options, as you mentioned, we have sub-Q options in either icatibant, which is a bradykinin receptor antagonist. Ecallantide is another subcutaneous drug, which is a kallikrein inhibitor. Then we have C1 inhibitor products, which replace the underlying deficiency in most people with HAE. So C1 inhibitor deficiency being the cause of the swelling, these IV medications, either plasma-derived or recombinant C1 inhibitor concentrates, also shown to stop attacks when they start. So I'm with you. That's the first thing I do after making a diagnosis is talk about this rescue or on-demand treatment that every patient needs, because these attacks are unpredictable, they're serious, they're debilitating, and they can be life-threatening. And just to reiterate exactly what you said, which is our practice as well at our center, as much as possible, making sure people can self-administer these medicines. 3 of the 4 medicines are approved for self-administration, the exception being ecallantide. So that should be given by a healthcare professional. But the other 3, icatibant, plasma-derived C1 inhibitor, recombinant C1 inhibitor, these can be administered by patients in their home. They just need to learn how to do it. And so that education for self-administration and subsequently early treatment to get the best outcomes is step number 1. Have this unwritten rule. Nobody leaves our office with an HAE diagnosis without having a prescription for a rescue medicine. And then knowing how to use it, knowing how to refill it, and knowing to treat, as you said, any attack that may happen and interfere with their activities. So that's step number 1. And then long-term prophylaxis. So Alina, there's been an amazing amount of development in the last few years in prophylactic treatments for HAE. So how does that conversation go?
It's a great question. And what I'll start with simply is the attenuated androgens are really second line treatment at this point. And a lot of that has to do with side effects. Even though they're efficacious, the side effects are of significant concern. And so with the 4 newer FDA approved therapies in the last decade, I think attenuated androgens have become second line. So the 4 main new therapies we talk about are lanadelumab, which is a subcutaneous injection for long-term prophylaxis given every 2 to 4 weeks. The other one that was the newest actually is berotralstat, which is a once-a-day oral therapy that has been approved for long-term prophylaxis. And then there are the plasma-derived C1 inhibitor products, which are inhibiting or which are replacing the missing protein in patients with hereditary angioedema. And there's subcutaneous and intravenous options given twice weekly. And I forgot to mention lanadelumab is a monoclonal antibody that inhibits plasma kallikrein. And so all of these therapies are, again, in the same contact system pathway, targeting decreased bradykinin production at the end, and all have been shown to be effective. And so talking to patients about, the route of administration, the frequency, potential side effects are part of the conversation. In addition to, do you feel that long-term prophylaxis is something that you would like to start? And if it's not today, we'll talk about it next time. Or even if you start today, it can be changed. We can change that decision as part of ongoing follow-up with our patients.
Yeah, and this is one of the biggest, I think, management questions that comes up, or that we spend a significant amount of time on, at least in my practice, is who or when do we use long-term prophylactic therapy? I mean, the on-demand acute treatment that we mentioned earlier, that's sort of a no-brainer. Everybody gets that. There's really no questions on that front. You got to have a rescue medicine to treat an attack if it occurs. But long-term prophylactic therapy is, not every patient may choose to do this, although increasingly more and more patients are moving towards long-term prophylactic therapy because, as you just outlined, we actually have these very effective and so far very tolerable and safe treatment options. And it sort of stands to reason that if you can, prevent an event, prevent a very painful and debilitating episode from occurring, a lot of people would prefer to do that. So I think this isn't a big surprise that preventing the complications of HAE sound better than waiting for it to happen and then dealing with, with the attack that occurs. So increasingly, we are having those conversations. The guidelines actually recommend that we discuss long-term prophylaxis at every visit with every patient, even if they choose not to go on that therapy. And the factors that go into using long-term prophylaxis are numerous. I'd be interested in what you focus on, Alina, but frequency of attacks is important. It does matter how often you have these swelling episodes, and I'd be remiss not to say that it's highly variable in HAE. Some people have an attack every week. Other people may have an attack once or twice a year, and everything in between. So frequency is an important consideration. The types of attacks that people have can influence their decision. But ultimately, at least in our practice, we try to evaluate how is the condition, how is the disease affecting their ability to carry out their life, their everyday activities, work, school, travel. We mentioned these things earlier. So I think it's more than just what types of attacks, how often, what complications have you had, but trying to get an overview of the burden of disease. You used that term earlier, and it's a great term because it is absolutely an important consideration. What's the burden of this condition on an individual's life, and how could long-term prophylaxis, address or improve that?
Agree, Mark. I think you described it really well. It's not just the severity and frequency of attacks. And some of the factors that we think about aren't really black and white. It's are you able to do the things that you want? Are you able to travel? Are you able to go to school? Are you able to go to college? How close is the nearest emergency room if you were to have a laryngeal attack? How expensive are these therapies for you? And sometimes those are more intangible, and we have to really remember to ask patients these questions. When you use on demand, does it work for you? Those kind of questions that are just as important as the nature, the frequency, the severity of attacks, laryngeal attacks. Did they have a family member that died of a laryngeal attack, and use that as understanding why they're deciding to do what they decide? And so I think in addition to everything you described, these are the burden of the disease. These are the burden and extraneous factors that are often just as important in making these decisions. So to tease that out, make sure you have a 360 conversation about all of these factors is really important.
Right. Totally agree. So as we kind of move through the management, we've set up an acute treatment, an on-demand medication for an individual with HAE. We've talked about long-term prophylaxis, and like I said, many patients will elect to go on a long-term prophylactic therapy. One quick important point: even patients on long-term prophylaxis still need an acute on-demand medicine, because while the newer long-term prophylactic medications are highly effective, none of them have proven to be perfect or 100% effective. So there still can be occasional breakthrough symptoms of HAE that need to be treated with an on-demand medicine. There's a couple of sort of, I guess, non-pharmacologic approaches that we always want to remind patients about. There are triggers for attacks of HAE. These do include certain classes of medicines. So ACE inhibitors should be avoided in HAE. Exogenous estrogens should be avoided in women with HAE because of that can actually trigger or exacerbate HAE symptoms. And then it's always important that patients make their healthcare team aware of any procedures. So surgery, intubation, endoscopies, major dental work. These can be iatrogenic triggers for HAE attacks. And we actually often will use a medicine for short-term prophylaxis, most often a C1 inhibitor treatment given just before these procedures or events that may trigger an attack. But then our patients use these management plans, and I guess, Alina, a quick word, what do you do next? I mean, do these plans sort of works forever for people, or what kinds of things do we need to be watchful for in follow-up of the management plan?
I think the management plan is never going to be a one point in time. And I think this is part of where ongoing care is really important, and maybe involving a specialist if you don't have a lot of familiarity with potential triggers or the guidelines or some of the newer therapies. And really the management plan is today, this is what is working, this is the burden of disease, this is the way that we're assessing it. But whether it's every 6 months or every year, really kind of going back to that patient. For example, it's a high school student that's going off to college, or somebody got a new job that we talked about. Those are all factors that will make changes in the management plan because that patient needs something different at that point in time. And it may just be a difference in IV versus sub-Q versus oral based on their experience. It may be that they now want to start long-term prophylaxis because they had a family member with a good experience, or they went to a meeting and heard a lot about it and feel more comfortable with it. And so I think those are the type of things that need to be discussed at every visit and then leads to a change in that management plan. So it's kind of a plan, but the same way like with asthma, where we continually evaluate it, it's the same way I think about it with our HAE patients and their management plan.
Yeah, these follow-up conversations are critically important to adjust the plan. Sometimes we'll adjust a dosing interval, we'll adjust the actual dose of the medicine. We may change treatments, as you said, change strategies, change medications. So there's a lot of moving pieces. We do actually have some tools now that can help us. There are both activity scores for angioedema, there's quality of life measures. One quick, easy one is the angioedema control test. It's literally 4 questions that you can use in the clinic to get a sense for how the patient's doing, in addition to these important conversations. And I put in a plug also for the US HAEA now has a shared decision-making tool that's available online and actually asks about a lot of these factors we've just been discussing, something a patient could fill out even before their visit with the physician, bring in this one-page report. And it really, I think, may help focus our conversations, because we all know that time is short with these visits, unfortunately, sometimes, and we can really get to what's important to that patient and individualize or personalize their therapy, which is always the goal. In the last couple of minutes, Alina, it turns out that the research hasn't stopped. There's still a lot going on in HAE therapeutics. And so we're looking ahead to potentially having some additional treatment options down the road.
It's an exciting field. And every time I think we've reached a point where we've gotten great therapies, there continue to be new developments in the area. And this includes less frequent dosing, potentially oral drugs for prophylaxis or even acute treatment. And really on the horizon, gene therapy, where we may have a cure, and certainly different stages of development for these different therapies. But I think the horizon remains bright for our patients because of all the companies and the therapies that are still studying better ways to manage our patients.
Yeah, it is pretty remarkable. And all this has really been on the shoulders of understanding the pathophysiology of HAE pretty well, at least for C1 inhibitor deficiency. So as you said, we do recognize, while we have excellent, very effective choices, that there is a burden of treatment still for some of these therapies, and this being a lifelong chronic disease, these ongoing efforts are really looking at, is there an easier, more effective, safer, more tolerable ways to treat hereditary angioedema. So as you said, a really exciting time, and we'll see what comes of these trials, but it's nice to see the research continue. I don't think we're quite done yet with trying to improve lives of patients and families that have HAE. So with that, Alina, thank you. This has been a lot of fun. I've really enjoyed it. Thanks for your insights. Any closing comments or summary statements you want to make?
I think that it's an exciting time for our patients because of how many FDA-approved therapies there are. And to make sure you have a good conversation with the doctor managing your symptoms so that you're getting the treatment options that you need and seeking that care. I think I would stress that to all of our patients that are listening.
Excellent. Thanks very much, Alina. And thanks to all of you out there for listening to the podcast. Have a great day.
Remember to receive your credit and evaluate this program. Please visit morningcommutepodcast.com/HAE2. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.